A lot of times you get solid particles, and even if you can suction the liquid, there are these solid particles that clog the scope, and then it's just, it really, you kind of almost, a lot of times you just have to have them reschedule it if it's this bad. One more short little video of a polyp being removed. This is kind of interesting.
Dr. Bajikman, now you're going to show us an actual polyp that you detected inside a patient's colon. Can you please explain the importance of a colonoscopy in detecting and removing these polyps, and whether or not, when you're removing them, does the patient feel any pain or do they have any bleeding?
So we're pulling the colonoscope back through a normal, healthy colon that's very well prepped, and you see this bump that this is sitting on top of a fold here. This is a large polyp at the splenic flexure, which I'm going to look at now with the scope. And we're turning a blue light on, which is known as narrowband imaging, which allows us to see the surface pattern with more detail. You can see the surface has a villiform or a stripe-type pattern, which suggests that this is probably an adenoma, which is the type of polyp that may have the risk of turning cancerous. And this is the type of polyp that we want to look for in a screening exam and remove. By removing a polyp like this, you prevent it from ever having the chance of turning cancerous. This polyp causes no discomfort, and the patient has no idea that it's even in there. The white catheter that you see that's coming out is actually coming through a channel in the scope known as the biopsy channel. And it's being used right now to just investigate how this polyp attaches to the wall. And what you can see is that the polyp is attached by just a little bit of normal tissue, what we call a little stalk. And we're going to use this snare, which is a catheter that has a loop of wire around it, to extend the wire out around the base of the polyp and then put electric current through that wire. You see the wire coming out now, and it's being surrounding the bottom piece of that polyp. We're going to now close that snare, and the patient feels nothing of this as this is being done. There's absolutely no nerve endings there. Now electric current is going to be put through that snare, and you're going to see the polyp start to turn purple and fall off. The reason it fell off is that the wire cut through the base and cauterized at the same time that it cut, so there's no blood or bleeding. We're using a water jet now to irrigate or wash that area where the cut has been made, and as you can see that the tissue looks completely normal and healthy there, so it's been completely removed, and we'll send the polyp to pathology.
So these are some of the most common findings during a colonoscopy. There are basically two types of polyps. There's something called the hyperplastic polyp that we really don't worry too much about. And then the adenomas, those are the ones that sometimes will develop into cancer. And then most patients, we see a lot of patients with diverticulosis. That's just these little pockets on the wall of the colon. And most of the times it never causes any problem. Sometimes if those pockets get infected or inflamed, that's called diverticulitis. And patients would experience lower abdominal pain and fever and often have to take antibiotics. So following the procedure, patients are again instructed that they're not to drive a car that day. They're given instructions about resuming blood thinners and antiplatelet medications. If no polyps are removed, then those patients can go right back on blood thinner and their aspirin and Plavix. If polyps are removed, we often request that they hold those for 7 to 10 days. Patients are told to resume their usual diet, and they're to call the doctor if there's any kind of severe abdominal pain or any significant bleeding. If just kind of crampy pain or gas pain, that's kind of to be expected. If someone passes just a tiny amount of blood, we don't worry about that. But if someone's passing more than, certainly cupfuls of blood, we tell them to give us a call. We usually have to send them back to the emergency room. And the patient should get their results. If polyps are removed, it's usually about a week before we get those results back. In the past, we would send letters explaining the results, and now we're trying to encourage patients. We have a patient portal where if you have an email address, you can sign up for our patient portal and you can get those results 1 week after the procedure. Now, if you do have polyps, then we recommend doing surveillance colonoscopies. So if there are no polyps or if they're only the hyperplastic polyps, those patients can come back in 10 years. If you have 1 or 2 of the adenoma-type polyps, those patients need to come back in 5 years. If you have 3 or more adenomatous polyps, those patients come back in 3 years. Sometimes if the bowel prep isn't good, we have patients come back sooner than that. If we're concerned that maybe a very large polyp wasn't completely removed, those patients will also often come back in 6 months to a year. So overall, this is just kind of summarizes some of the things that we talked about. Colon cancer is the second most lethal cancer in the United States. Average risk patients have a 1 in 20 chance of developing cancer in their lifetime. There are 136,000 new cases diagnosed each year in the United States. Only 2/3 of patients are being adequately screened for colon cancer. It does take a long time for a small polyp to develop into cancer, as long as 10 years. And then by doing these colonoscopies, I would like to think that they're perfect, but it's not completely perfect. It doesn't eliminate the risk entirely, and some of that may be due to the bowel prep. If you have a less than a perfect bowel prep, it's very easy to miss small polyps that may develop into cancer. So there should be no excuses. Just because you feel fine, that's not an excuse. Men and women both are at risk for developing cancer. Even if you don't have a family history, you're still at risk. So in summary, again, 3rd most common form of cancer, 2nd leading cause of cancer death. We think colonoscopy is the preferred test because we can detect and prevent colon cancer. Average risk individuals should begin screening at age 50. We think African Americans should begin screening at age 45. Mentioned before, the average risk is 5% or 1 in 20. We get the best bowel prep if the bowel prep is split, taken half the day before, half the day of the procedure. There are 2 types of polyps. They're either hyperplastic, we don't really worry about those, and the other type are the adenomatous. And the adenoma, we think all colon cancer comes from adenomas, but not all adenomas will develop into colon cancer. If you do have a family history, then we should begin screening at age 40 or 10 years before the relative was diagnosed. And then screening should be discontinued at age 85 or when a life expectancy is less than 10 years. So you can talk to your doctor out here about screening options. And I think Dr. Pitts and Dr. Sides are all real good about getting after patients, about having their colonoscopies done. I bet out here, instead of the only 2/3 patients being adequately screened, I think a much higher percent of patients are being adequately screened out here at SIPCO. Nurse Snow is also very, very good about getting after her patients and having their colonoscopies. Do you have any questions for me? Well, yeah, when someone does develop symptoms, it usually indicates there's a very large tumor and, I guess, bleeding. Someone begins passing blood. Men are notorious. They'll ignore that and say, oh, it's just my hemorrhoid's bleeding, and then they come back a year later and we find out, they have a rectal cancer. Some patients will have abdominal pain if they get a big tumor that is obstructing the colon. But most of the times these polyps cause no symptoms whatsoever, and that's why I recommend, even though you're healthy, not having any symptoms, a screening test is done in someone who is asymptomatic, that don't have any change in bowel habit, they aren't passing blood, they're not anemic. And I think we can make a big difference by doing these exams. So how many in the room have had colonoscopies? I guess I'm preaching to the choir here then.
The worst part is to do.
It is. But it's gotten a little better, instead of drinking the whole 4 liters the day before, we're doing these lower volume preps and doing half and half. And maybe it's a pain in the neck getting up in the middle of the night to do that second dose, but if you get a better bowel prep and a better exam, I think it's worth doing that once every 10 years. So if you don't have a good bowel prep, we're kind of hesitant to say, if you have, if it's not an excellent prep, if there's some liquid or some solid there, instead of coming back in 10 years, even though you don't have a polyp, we may say, wait, you probably should come back in 5 years.
So when you split the prep, how many liters is it?
Well, it's actually,
different,
it's
right?
lower, yeah. The soup prep and the movie prep are low volume preps. And then we're doing a lot of this Miralax and Gatorade, which is a 64-ounce Gatorade. So if you split that, it's 32 ounces, 32 and 32, which, again, I think it's about half of what the 4-liter prep was.
Yeah, the gallon is really bad.
I remember when I had my first colonoscopy, and you always heard patient, I got all but this much, and when you do that, you realize that it is really hard to drink that 4 liters the night before. And then being on that liquid diet, I think I found that was the hard part too, to only broth and jello that whole day before. You don't want to be like Dr. Oz. He had his colonoscopy on TV, and he had lentil soup the day before, and his bowel prep wasn't good. And his doctor made him come back. So he was shamed on national television for not following instructions.
What about something like Boost?
Well, that's not clear. So,
Oh, okay.
so yeah, you really want something that if you put it in a glass and held up, some print or something, you should be able to be able to read through it.
How about diet? Is diet, as far as is there any particular diet that prevents?
Well, I guess that trying to a diet heavy in red meat, high fat diet, those are the bad diets. I think the cured meats, the bacon and ham and sausage, smoked and cured meats are associated with a little bit increased risk of colon cancer. So, anybody watch the bad colon prep again?
If you have a family history, but your screening is clear, is it still 10 years or should it?
Yeah, with that family history, instead of 10, it should probably be 5. Most would recommend 5 years coming back, even though you have a normal exam. And I guess we worry most about that first-degree relative age less than 60, or 2 first-degree relatives at any age. Those are showing a higher risk.
And that is if they had colon cancer, not just the polyps, right?
Well, I guess they also say if you have a relative that has a polyp that has a high potential for developing into cancer. There's something called a villus adenoma. And we really worry about those patients, but it's really hard to know the details about your relative. Well, you may know that maybe they had polyps removed, but you're not going to know that you had a villus adenoma. It was 1 centimeter, and it was a high risk polyp for developing into cancer. Okay, I guess we're.
Thank you.
You're welcome.